Okay, welcome back to the Barbell Medicine Podcast. I'm here with Dr. Baraki. I'm Dr. Feigenbaum. This is the second part of our question and answers series. Austin, how you doing, buddy?
I'm doing okay. I hope I'm coming across loud and clear over there.
It is possible that Austin has contracted chipmunk's disease. Now, if you're not familiar with chipmunk's disease, what it is you have two novices when it comes to audio and visual technology, and sometimes your mic makes you sound like a chipmunk. Austin, I think, has a severe case.
It's terminal.
This terminal we just called a palliative care consult, and I think we're going to put him on hospice. So
Yeah, I don't know what to do about it, but we're just going to run with it because we want to deliver this content. You know what I mean?
I would like to point out that Austin indeed does sound like this on a day-to-day basis. And his wife, Lorraine, graciously puts up with it. On the tap today, we're going to talk about nutrition, and we're also going to talk about miscellaneous questions. So we'll start with the miscellaneous questions, jump right into it, and then we'll finish up with nutrition. All right, so Austin, same format as last time. I will ask you the question, you will respond, and then we'll switch it up for the nutrition section. First question by Lactate is Love. I'm currently studying physical therapy, and since I've been reading starting strength material, I find it hard to believe my PT course content. Smart guy. Do you guys have any advice on how to become a decent PT? Question mark. Dr.
Yes.
Barkey.
So there fortunately are starting to be more and more PTs who are interested in training and in actually providing useful stresses to their patients, stresses that can result in recovery and adaptation, i.e. useful adaptation, typically in the context of increasing physical strength in their patients for rehabilitation purposes. So I think if you're already reading our material, that's a good start. Make sure you thoroughly understand the concept of stress recovery and adaptation as a model in terms of how you can apply it to exercise selection, how you can apply it to programming, and how you can apply it in a rehab context. And we have a few physical therapists in our organization, and there are more and more who are good resources for you to look into, and they're pretty easy to find in the barbell and rehab worlds. So I would start out there.
Yeah, I agree. I think something that you and I had talked about, I believe it was last week or the week before, was that things like chiropractic medicine are actually at odds with our training model. And what I mean by that is we kind of preach this stress recovery adaptation cycle being germane to the process of getting better physically, right? And I don't think that PT is explicitly against that. In fact, their model is built on the same thing. It's just the methods that you use in order to derive that. So it'd be very hard to do with like a band assisted or band resisted sort of external rotation against a half a pound of resistance or something like that. But that model works with pressing or other exercises and training stuff that we do. Whereas chiropractic medicine, which requires a little more length of education and perhaps potentially more cost, does not necessarily comport with those ideals. So I think that it is possible to become a decent PT. Just the modalities that you use for your rehab are going to be different than likely what you learn, unless you happen to go to where's Patrizio at? Adelphi? Is he at Adelphi?
Adelphi University, that's right.
Dude, I just can't get over your voice right now. This is great.
God damn it.
All right. So I think you could do it, and ultimately that would be a big service because I think you probably run into the same issue I do, which is if you need to refer to PT for whatever reason, you don't really have good options unless you happen to personally know the
special therapist, right? Yeah.
Yeah.
And so I would encourage you also to just be aware of the Choosing Wisely guidelines that were put out by the American Physical Therapy Association. I think number one of which is to not underdose your strength training interventions, particularly for your older patients. And that just, again, comports with you need to deliver an adequate stress in order if you're going to get anything useful out of it, rather than wasting 12 weeks doing 3 sets of 10 on the TheraBand, like I see a lot of my patients end up getting when I have to refer them, because that's what I have available to me.
Yeah, one more interesting note is on your personal opinion, your professional opinion, how about that? When is it appropriate to order inpatient physical therapy?
I have to do it all the time.
Oh, no, I know. Look, if you get into the hospital and you're like, a human You're a carbon-based life form that's
placement, man. Placement. That's what it's all about.
Yeah. I think if you have to have a formal evaluation for placement or for DME, durable medical equipment, then sure, ordering PT is useful. But actual acute rehab inpatient, unless you're at an orthopedic facility that just you're going to keep patients for a long time, which is not. That usually that'd be a SNF or a skilled rehab kind of situation. Ordering PT in the hospital, just not. I mean, we keep sending papers back and forth to each other like inpatient PT of no utility, basically.
There's the article that I cited in the previous one that I wrote that was related to hospital-acquired deconditioning and kind of the role that physical therapy has to play in it. And they're in a position where they can do a lot of good. And of course, they do help our patients start moving, and that might prevent some complications that we would otherwise see. But I think there's a lot more potential there, as was elucidated in that article. So it's not just our opinion. It was actually an article put out in the American Physical Therapy Association Journal. So it's not just our bias that's saying this.
Notice the American Physical Therapy Association Journal even said this.
Hospital-acquired deconditioning, yeah.
Which is different. Which is different than critical illness myopathy, but that's for another podcast. Okay, David Blackstock asks, what are your plans as far as coaches and doctors? If a time comes that coaching/seminars are enough to sustain your income, will you ever stop being doctors?
Interesting timing for this question. So this is actually one of my clients. I've been coaching him. He was my first ever coaching client, I think, and we're still going strong. Let me get this cat out of the way. So our plans
cats are associated with chipmunk disease.
This is true. Yeah. So our plans are, I feel like they're complicated and they're changing very frequently. Like there's new developments between both of our plans happening all the time. And so me personally, speaking about on my own behalf here, if time comes when coaching seminars are enough to sustain income, I would not plan to stop being a doctor. I feel like I really enjoy the balance that I get between the two fields. I couldn't be a coach full-time or own a gym by myself and do all the coaching for it, and because I would feel like I would get burnt out. And probably the same thing would apply if I do really intense, like if I was to become an intensivist or something like that. I could not handle that. So I really like the balance I get. I see full spectrum of illness to wellness, and I see complex medical issues that I get to think through and treat, but I also see the highly motivated patients who come to me and they want to get better and they want to get stronger and take care of themselves and be models of healthy aging. So I enjoy the balance. In terms of what exactly my future practice is going to look like, again, this is all dynamic, and I feel like Jordan will have an interesting answer that I'll let him talk about, and that might be an interesting collaboration in the future.
Thank you for this interesting consult. So I guess, from a semantic standpoint, you'd have to define what does being a doctor mean. I mean, if you're talking about working in a clinic, in a hospital, I don't plan on ever doing that. So that's never really been my plan, mainly because there's no current healthcare job, a doctor job that actually fits what I want to do, which is mostly preventative medicine or health promotion in the community. So in any event, my income is what it is, and I don't think that necessarily needs to be public. But at the same time, being a family medicine physician would be a decrease. So I don't necessarily want to do that. In any event, I do like the skill set you get from being a physician. I certainly like working on that higher level cerebral standpoint where you have more knowledge to help people really make a difference in their health and health outcomes. But I think the overall plan is to merge legitimate strength and conditioning and lifestyle interventions with westernized medicine and spread that idea via remote direct access medicine. That's, I think, the direction I'm headed in, mainly because I get emails all the time, and I feel like Donald Trump whenever I say that. People are telling me, or people are asking me all the time. Every time I say that, or if I say the word perfect or great, I just feel like, damn it, this is. But yeah, people ask me all the time, who's a good doctor I can go see? And I'm like, I don't know who you could see over there. There's probably nobody that's going to understand your training, or be able to sufficiently counsel you there. And in addition, they're only going to see you for 10 minutes anyway, so you probably wouldn't get to talk about it. So I think making that available to people is going to be very useful. I certainly think we still need our specialists and our intensivists and everything else, because you can't do that outpatient,
right.
Certainly remotely.
Somebody's got to do it, right?
Yeah, for sure. It's just not necessarily what I want to do. So I think Dr. Baraki and I will both be involved in that on some level, and more to come in the near
It's gonna be
future.
exciting stuff, man.
We're changing the world.
Yeah,
We're
let's
changing
do
the
it.
world. All right. Kearns Mark asks, is there, I'm going to say, I think that he means are there 5 tips and ideologies that you would recommend for the average bloke? Training, diet, and health.
Oh, that's an interesting question. I don't know really what you're looking for when you say for like an ideology, but just basic tips. I feel like you're probably going to acquire a lot more than that in terms of useful tips just from listening to these podcasts. But you should train. You should train with barbells using the methods that we describe. Your nutrition should be, I can say intelligently designed in line with To Be a Beast article. That basically is, will do the job for most everybody. Um, Take care of your sleep. Don't smoke. And then, techniques for mental health and stress management and things like that to keep you a happy person. I think that's a reasonable set of 5.
That's pretty good. That's a nice set of 5. Yeah, I probably would agree with that. Yeah, lift progressively heavier barbell or weights with barbell training. Eat within the constructs in To Be a Beast article. I think is a reasonable recommendation. I would agree with that. Don't smoke. Have good interpersonal relationships and psychosocial support via those, and sleep like you actually care about living for a long period of time. Which brings me,
Great.
yeah, exactly. Yeah, after residency, later I'll sleep. It's interesting. I was at Barbell Brigade the other day, deadlifting, and this guy, which is weird. So here's the thing: if you're training hard, the last thing that you want is somebody to come up to you between sets and ask you an irrelevant question, like something along the lines like, "Hey, what kind of so when should I use straps?" It's like,
I don't care.
yeah, like ask me a few hours from now, okay? Like,
Yeah.
all right. So anyway, this guy is talking to me, and he's like, yeah. So I'm studying why humans need sleep. And I was like, you're studying why humans need sleep? He's like, oh yeah, like because it's so weird. Why do we need to sleep? And I'm like, this seems like something you're not really studying. Like I was.
Seems like time that might be better spent sleeping.
Yeah, exactly. Like I was about to go like, well, the reticular activating system and sleep drive is a very complex biochemical process and this and the other. And then I was like, okay, I still need a few sets left, so I'm just gonna stop. Yeah, that's interesting. But I think that's a good set of 5. So training, food, psychosocial support, don't smoke, have a lot of sex. Is that?
Yeah.
Yeah. Okay. Matt Pasqualone asks, when your patients are in need of therapy, can you describe what exactly you would look for when recommending an outpatient facility? What would an ideal facility run by a strength coach look like, if at all possible and practical?
So this is not a question, I'll admit, that I've thought about very much, just because it's not something that I have access to. And so it's not something that I strike out and search for to find, because really, to my knowledge, at this point, it doesn't exist. I know of good therapists out there who are, training their patients and helping them get stronger. But in terms of a facility, what it would look like, well, it would be focused on strength and conditioning, really, in a very similar way to a gym that would look when we're training healthy people to get stronger. It might have to have some additional equipment here and there that would really be at the discretion of an educated and intelligent therapist in this kind of stress adaptation recovery model. But it would basically need to look pretty similar to a strength and conditioning facility.
Yeah, I imagine, something like Horn strength and conditioning with maybe a few more tools, or exercise training tools in there.
Things to accommodate for special situations. Yeah.
Yeah, attached to, a 4-room clinic with the procedure room and, a really nice atrium with a very fancy entryway so people feel like, you're walking into someplace nice. And you've got a good PT or in there, and you got a good psychiatrist there as well. And
Yeah.
I think ultimately that's the facility. So that's Barbell Medicine,
Mhm.
the storefront. Also, we'll have a lot of Gains RX as well. It's the whole line. Okay. Bacon is rad. Would you and Jordan ever consider running a clinical trial and teach people with back pain to squat and deadlift and check the results in 6 months? Or a similar one measuring the degree of insulin resistance before and after a 1 year starting strength program? I'll answer quickly. No, I would never consider doing that because it sounds like a huge time sink. Well, not that it sounds like that is a huge time sink. And for me, the opportunity cost is too great for the impact that would make in the academic field. So even if you and I just did this 6 month or 1 year huge multi-center, hundreds of thousands of patients or whatever, the actual impact that would have on getting people under the bar is minuscule compared to opening that facility that I just talked about.
And making it happen.
And making that profitable, available, and then open sourcing that.
Yeah. Yeah, I agree. I'm not particularly interested in clinical research. However, with that said, and this isn't actually something that I haven't even told you yet. I just recently got contacted by a professor in the nursing department at a university in Florida, and he is particularly interested in our model of training. And he's actually wanting to run a clinical trial. He wants to start it out actually like maybe a pilot or a proof of concept kind of thing in healthy individuals, and then based on the results of that, move on to people with various medical issues. And so I'm trying to help them out in terms of as like a medical consultant and starting strength coach in trying to make this thing happen. So we'll see what ends up coming of that. But me as a PI or you as a PI on one of these studies, ain't going to happen. And besides the whole deal about measuring insulin resistance in patients, but we're just not going to do that. I'd rather just coach thousands more people in that time.
Yeah. It's just our skills are better used elsewhere. And then, I don't actually think you need the 6 month trial on back pain. We already know that training, helps people with back pain do better on virtually every objective measurement, even if it's and the insulin resistance thing is nuanced. I would also like to commend myself for just setting a PR. It's been 22 minutes, and that's the first time I said the word nuanced. So
nice, yeah.
Yeah, PRs today. All right. So we will now move into the nutrition section, which is going to be a lightning round. So we've got some nutrition questions. Let's hope. I haven't read these.
So do you want me to lightning round you on these?
You can, and if you have things to add, I think.
Sure.
Yeah, let's do it.
All right. So InstaKilo91 asks, I'm curious, is saturated fat stuff blown way out of proportion? I remember reading an article with good evidence that dietary intake of cholesterol does not affect blood cholesterol levels. Subsequently, blah, 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 blah. Now rumor has it FDA is in talks to remove cholesterol from the nutrition facts. Can we foresee a similar fate for saturated fats?
So I'm unsure if that movement within the FDA is actually occurring. I doubt it. And then I don't know if I would agree that, say, that dietary intake does not affect cholesterol levels, because it certainly can. It's a small effect, but to say it doesn't affect it, that would be just wrong. And certainly that saturated fat or dietary fat intake doesn't affect blood cholesterol levels would be an incorrect statement as well. To the effect that affects your cardiovascular risk profile is multifactorial, and I think that's ultimately where the rub is. If you are just making the association that eating more fat puts you at higher risk for cardiovascular disease, I think that's oversimplification, and that's mainly what people have been, clamoring against. So ultimately, what you're going to see is more and more research come out, better and better risk stratification of people for who a further cardiac workup is needed. But as far as what you should do practically, I think that the idea of eating a lot of saturated fat, as far as your fat sources go, is probably not the best management. And that doesn't mean avoid saturated fat. It just means that I don't think you should go out of your way to say, well, it needs to all be coconut oil or butter or
blended in my coffee.
Yeah, exactly. Yeah, there's been case reports that have come out that people doing that have had dyslipidemic changes that were previously had normal lipid panels. Now, I'm
not surprised.
Yeah, to the effect that actually changes their cardiovascular risk profile. We don't know.
Yeah, it's kind of funny. In the same way that people clamoring about dietary fat causing heart disease and stuff like that directly, unidirectional, 100% of the time idea was an oversimplification. Lots of people reading too many blogs out there and not the actual primary literature are going in the other direction and saying, no matter what I put in my mouth doesn't actually affect my cardiovascular disease. Or fats do nothing, but really if I have 10 grams of sugar in a day, all of a sudden I'm going to thrombose all three of my coronary vessels. It's like kind of ridiculous.
And get diabetes at the same time.
Yeah.
Yeah, any sugar, you're dead.
All right. Jake Lift asks, thoughts on ketogenic diets for strength training?
Yeah, I think that's a terrible idea for performance. I certainly think that a few in the strength conditioning field with decent sized audiences have been putting out sort of anecdotal evidence that, oh, I've been doing keto and things are going great. And I think that that's ultimately short term. Like, oh, things haven't gone poorly. And then also these are people who are well trained previously. And you're sort of seeing, hey, this person's well trained previously. There's a lot of factors that go into their performance on any given day or at any given event. And that sometimes doing a ketogenic diet or whatever version of the ketogenic diet they're doing doesn't necessarily tank them. All right. But what you're not seeing is people who are starting out untrained, doing a ketogenic diet, making the types of improvements that we want to see, and the additional layer to that is, why are you doing a ketogenic diet in the first place? The supposition is that you're going to lose body fat faster, which is not supported by evidence. Okay, when you look at long-term data, the body fat, and weight loss at a year there's no significant difference. All right, and then further, if you're losing weight, guess what you're not doing?
Gaining muscle.
Yeah, it's not happening. So it's not like there's no secret trick. Okay, like there's no that one weird trick.
Weird trick.
Yeah, that one weird trick to getting big, jacked, and lean is to train really hard for a long period of time, eat like you give a damn, and then don't get married.
I'm doing all right so far.
Yeah, this is why when people ask Austin who's more jacked, then Austin just says, "Well, I squat more than he does," and then that's fine. That's fine.
Right. Yeah, it's all right.
It's all right. All right.
Dear Dr. Beasts, after training with Colin Ragavan in the UK, I noticed after about a year my Crohn's disease flare-ups reduced to practically zero. In that time, my body weight went from 70 to 85 kilos. What are some hypotheses as to the mechanism for reduction in flares? Improved carbohydrate tolerance?
I don't think that, carbohydrate tolerance, well, that's kind of a vague term, but you could make the argument. I know people with Crohn's who have, comorbid diabetes, whatever. Not that it's the same mechanism, but if you have diabetes and also Crohn's, you do worse just from basically any objective measurement. I would suggest that actually the physiological milieu that you're placed in from training is likely beneficial from a Crohn's standpoint, or just inflammatory bowel.
I think that's the answer. Is talking about like the myokines and stuff like that that are coming out now as improving the inflammatory kind of environment in the body.
Yeah.
That'd be my suspicion.
Yep, I would say that too. And then in addition, you probably also learned trigger foods or trigger sort of activities that make the Crohn's get worse, and maybe you're just avoiding those and you're not necessarily able to see that unbiased because you're like, oh, what do you mean? This is what I do. And so I think those two things are probably my biggest things. Yeah.
Cool. All right. Taylor B081. Have you had success getting your patients to train? If so, can you share your approach? As a physician myself, I'm always looking for ways to help my patients improve their health.
So I have actually not had decent success, mainly because it's very difficult to do in my situation. I'm seeing mostly people like post-discharge clinic or folks who are not necessarily interested in training. That being said, I have had what I would consider above average success talking to people about training because I actually do it every visit that I see somebody. I actually talk about exercise because it's important to me, and two, what I'm recommending is this sort of training, and I give people resources. So as far as what my percentage conversion rate is, I'm not sure. And I think ultimately, I would say my limitation is time, because I'm still, unfortunately, stuck in this sort of, I can only see you for a certain amount of time because we have more, I have to go precept you with somebody who doesn't care about your training, who'd rather wants to make sure that, you've had your yearly lipid panel so we can make sure that you're on the correct dose of statin, which I'm not saying is unimportant. I'm just saying, on some level, we just need to stop stop worrying about the numbers as much as actually behavior changes. Because the reason why the person is going to get placed on the statin in the first place may be because they're not, be doing this stuff. So.
Yeah, I agree. My patient population is, I'm in a similar situation, my current patient population. So it's challenging. Just got to keep hammering away. And, I suppose that if you have X% as a conversion rate, then the more people you end up doing it to, the more people you end up hopefully getting to help. But exactly. More of the people that come to me, contact me as, for coaching, even those who haven't been coaching, who haven't been training before, that's kind of where most of my training kind of focus is.
Yeah. Yeah, because you're already getting people who are basically interested in training. Yeah. I think anybody I think that anybody you get who's open to it in the office was already open to exercise in the first place, and now you're telling them, I need to do strength training. Yeah. And they're like, but I thought I was just supposed to walk. So I never say, just walk more, because that's bullshit.
Yeah, just spend a little more time gardening. That'll be the training.
Yeah, if you garden or play golf or was that a cattail?
Yeah, it was. All right, let's bang these last ones out.
All right.
Eddie 73, early morning training, peaceful, uninterrupted gains, or road to the chiropractor because my spine hasn't woken up.
I'm not familiar with the research on the circadian rhythm of the spine. I suppose there's some
vertebral amnesia.
Yeah. There's some connection between your reticular activating system and the intervertebral discs. That being said, I think the biggest thing is hydration status, your sort of how aroused you are for training. So I think we have some pretty decent evidence that about 7-8 hours after waking up that your performance level is its highest due to a whole source of factors. Just again, you're more awake, you've been well fed, you're well hydrated in general. That being said, if you have to train first thing in the morning, you don't have a choice. What are you going to do? Not train?
That's took the words right out of my mouth. All right, next question. J. David Thompson. What effect does early morning workout have? We kind of just answered this, right?
Yeah. Eat some toast, BCA, start training around 4:30 a.m. Has your body started absorbing any food? Yes. And you're just setting up for failure. No, I would, if you can train at 4 p.m. instead, that's probably a better situation from a performance standpoint, but not training is the worst option. So if that's when you have to train, go for it.
Exactly.
Yep.
Pope Scott, question. In attempting to get my protein levels high on a daily basis, 200 grams per day, I'm also getting high cholesterol levels as a negative side effect. Any suggestions?
Without knowing the exact numbers, that's got to be hard to comment on. There's some evidence suggesting that people doing a bunch of whey actually have an increase in cholesterol levels. In addition, depending on what your protein sources are, you may, the dietary cholesterol thing has just a small effect. I would also be wondering if you're gaining weight, and then what, sort of your calorie intake is as a whole, in addition to your family history of just, cholesterol. So if it's not above normal, this is not. Just forget everything. Forget everything I just said and don't worry about it. So, if it's going up a little bit and it's still within normal range, again, just stop. Just you rewind, take back the last 45 seconds of your life. Right? So my things would be if you're doing a lot of whey and your cholesterol levels are above normal, then you could cut the whey out for a little bit. If you're otherwise above normal, and that's a new development for you, then I would start looking at refined sugar intake, making sure your fiber intake is on point. There's also some evidence actually that 20 grams of soy protein per day actually decreases LDL, which is and no, it doesn't increase your estrogen levels. Repeat.
To preempt that question for the next one.
Yeah, because it doesn't. To any clinically significant effect. No, you're not going to get boobs. Maybe you will, but I think
I accidentally ate a soybean once, and now I have giant breasts.
Well, I think that would be good to see on the internet. There was actually an article in Men's Health about this guy who was drinking like a liter or something or a gallon of soy milk a day, and he said he got boobs from it. And I'm like, you sure you just
probably because he got fat?
You got fat. Yeah.
Yeah. All right. Last question. Ahmed 725. How do you approach training during a month of fasting, Ramadan, from sunrise to sunset? That is a terrible situation. I don't practice any sort of religion. I don't do Ramadan. However,
don't lie.
Yeah, when I was in college and swimming, one of my teammates was Egyptian, and he would practice Ramadan every year. And typically, the month would fall during our training season because it would be, August on the early end, sometimes in the fall. And so basically, what the team would do, because college varsity sport, we're in the pool 9 times a week or something like that, in the weight room 3 times a week, just spending 20 to 30 hours a week training, and he can't eat from sunrise to sunset. And so it was horrible. He would lose I was impressed that he would only lose like 17 to 25 pounds during that period of time. I would expect him to lose a lot more. And so basically one teammate every single day would pick a day to do it with him, just to kind of show of solidarity. Like, we're going to, and I remember doing it. And it was just I was absolutely ravenous for the entire day, just trying to shut my stomach up with tons of extra water. I was probably putting myself into
yeah, your hyponatremia,
bad hyponatremia or something like that. So yeah, I mean, it's a pretty rough situation. It's certainly far from anything that could remotely be considered optimal for training. You're going to lose a bunch of weight. You're probably not going to gain significant muscle, not going to make significant progress in the gym. Yeah, it's just not a good deal. But you got to do what you got to do, I suppose.
If you're going to practice, then I suppose, at that time you're going to have to do a lot of calorie intake at night. And I think that, bears repeating that you should probably be tracking that, because using, I'm not hungry anymore, that's not going to cut it during that situation, because you're just going to undereat, likely.
Have to bolus meals every hour until you go to bed after sunset, just to get enough calories in. Maybe even wake up before the sun rises and get some more in.
Yeah, exactly. Okay, so I have a few questions for you, Dr. B.
How are you going to do this to me?
What are you reading these days? This is important.
What am I reading?
Yep.
I'm currently reading lots of material on patellofemoral pain syndrome, in terms of medical stuff, and then I'm also reading a book called How Doctors Think.
Ooh, how is that? I haven't read it yet.
Yeah, it's good so far. It's stuff that, interestingly, we were trained a good amount in the details of this book through our training at EVMS. So shout out to EVMS for giving us some good teaching on that stuff.
EVMS, I don't know if you know, this is a for-profit institution. It's a degree mill. I don't know if you remember that.
Yeah, I do remember that.
Facebook. No. Yeah, okay. Well, good. I'm excited to read that. I'm reading The Upside of Irrationality, which basically just questions how we think about everything. So anything, we're super biased. We are poor predictors of really everything. So every time, it's like, what's your clinical impression? And I'm like, I have one, but I'm pretty sure it's wrong, just in general. Yeah. And whatever your clinical impression is probably wrong too. Okay. Another question. In the past week, what has been your best moment from training?
So, as some people who have been aware of my training might know, I was unable to train the bench particularly heavy for quite a while in the past year, due to what I suspect was some sort of tendinopathy in my armpit that got pissed off and was hard to rehab for a while. So my bench appears to finally be coming back online. I titrated up the volume pretty gradually, and then finally this past week, my first 2 days of training, I think I benched something like 12 sets on the bench on Monday, and then a few more on the subsequent day. So my volume tolerance is going back up without any discomfort on the bench, so I'm happy about that.
How many chiropractor visits did that take?
52.
52. You did it weekly for a year. Okay.
Yeah. I prepaid. They gave me a little discount.
You prepaid? Yeah. You paid them all. Mine would have to be, that 675 pull was...
That was disgusting. It was really nice.
And the good thing is, there was a girl looking at me the whole time. I saw her out of my periphery, and I was like, I think she was impressed. She was impressed. Yeah. All right, last question. We both do Instagram Lives pretty regularly. All right. What has been your favorite or best question, if you can recall, from your...
Yeah. By the way, you know about William Howard Taft Official, right? He's a pretty funny guy.
Yeah, well, the screen name alone. Yeah.
He's like, to 17 checking in.
Yeah.
The one question that was interesting, made me think a little bit, was what was the most terrifying thing that you learned in medical school?
Oh.
To turn this into a next level, second order question. What do you think you would say? I can tell you my answers if you want to know.
It wasn't that what I learned. It was just the experience. So it was on surgery third year, and I had a lady with Fournier's gangrene, which if you don't know, so Fournier, yeah, so Fournier's is basically Fournier was a guy, dermatologist slash syphilisologist, like he's a syphilis expert, right? And he basically thought that any disease you had in the genital area was a sinful, you got it because you were sinning, like you were masturbating, which is obviously a sin. In any event, it's basically flesh-eating bacteria of the groin, and I'll never forget the smell of that. It's like barbecue Lays that had somehow gone rotten, and I'm pretty sure that barbecue Lays don't go rotten. That's just not a thing they do.
Engineered that way, yeah.
Yeah. So that was the grossest.
Yeah. I ended up narrowing it down to 3 things, and you can see what you think about them. Number 1 was the vivid image that I remember from pathology when we were learning about worms. And it was a picture of like an 8-year-old kid face down on the table, facing away from you with like 300 worms just like blowing out their backside. That was one that's never
left. Is this the pinworm?
Yeah. I don't think it's pinworms. No, it was like ascariasis or something. It was like a legit, like a big worm that you could see like grossly. Yeah. And then the other ones were locked-in syndrome. That's another terrifying one.
Oh,
just
yeah.
The whole idea of it. And then the other one was the idea of like getting like an ocular melanoma, like in the back of your eye, just like this completely lethal cancer that'll come out of nowhere. You didn't do anything to get it, and it'll kill you. That was the other terrifying thing. So,
on that note,
have a nice week, guys.
Yeah. No. So
we just 42 minutes, better than an hour and 40.
Yeah, so I think we'll cut it here. Looks like the next podcast will likely address these injury questions with your PT friend, Derek. What's his last name?
Derek Miles. We're going to have a guest on the show next time.
Derek Miles is basically the human repository of PubMed. Effectively, if you say a word, it's an auto search in his head, and he ends up spitting out all this data, and we'll be fortunate to have him. So in any event, thanks for joining us here on the Barbell Medicine Podcast with Dr. Baraki graciously joining me, and we'll catch you guys next week.
Great. See you guys later.